Thank you all for joining today. My name is Dr. Katie Liveoak, and I'll be presenting opioid use disorder, evaluating risk of return to use. The objectives are here and will include defining the scope of the current opioid epidemic and its implications for clinical care, to characterize the risk of return to use in individuals receiving treatment for OUD, identifying factors influencing sustained recovery versus return to use, and then we'll examine some data from AEGIS on return to use detection. Although opioid use patterns will vary by drug type, geographic region, and population, reports are suggesting a decline in opioid-related mortality, and this can be somewhat misleading. The United States is currently experiencing what has been termed the fourth wave of the opioid epidemic. The fourth wave of this epidemic is defined by the combined use of illicit fentanyl, and this including fentanyl analogs, with polysubstance use, particularly the rising combination of opioids and stimulants. There is also rising use and detection of non-fentanyl synthetic opioids such as nitazines. The current crisis is marked by overdose deaths, increasingly involving fentanyl mixed with methamphetamine, cocaine, benzodiazepines, alcohol, and gabapentinoids. The polysubstance pattern is especially concerning because it both increases overdose risk, but it also complicates treatment because the medications we use to treat opioid use disorder do not address any type of stimulant use disorder. Data shows a very sharp increase in stimulant and opioid polysubstance use, with methamphetamine and fentanyl dominating in Western states and cocaine and fentanyl combination dominating more in Eastern states. Between 2010 and 2021, overdose deaths involving fentanyl and stimulants rose more than 50-fold in the United States. I also wanted to note, it's not on the slide, but there is a subset of senior adults, those individuals aged 65 years or older, that have a increase and concerning trend in this fourth wave. In 2023, we noted a 50% of all of the fentanyl deaths involved a stimulant in that patient population, which represents a 9,000% jump over the previous 8 years. And then within that subset, you're also dealing with racial disparities where non-Hispanic Black individuals have higher rates of overdose deaths with fentanyl and stimulants than other racial and ethnic groups. Approximately half of all overdose deaths now involve both opioids and stimulants, and this just highlights the need for integrated harm reduction strategies, increased and continued access to naloxone, and expanded access to medication-assisted treatment, or MAT. That would be buprenorphine, methadone, and naltrexone, and ongoing public health efforts. Individuals with OUD who do not utilize MAT face return to use rates as high as 80 to 90%. This high risk of return to use highlights the chronic and relapsing nature of this condition. With interventions like buprenorphine and methadone, rates can decline to approximately 40%. So MAT reduces but does not eliminate the risk of return to use. And despite the benefits of treatment, successful long-term abstinence remains quite uncommon. And that's a similarity that is shared with other chronic diseases. So thinking about hypertension or diabetes. And this emphasizes again the importance of harm reduction approaches to mitigate the risk of overdose death. And those would include early identification and detection of return to use, in addition to those evidence-based treatment options and access to naloxone. Definitive testing in OUD care is used for monitoring treatment adherence, detecting non-prescribed drugs or illicit substances, and early identification of return to use. It provides a more accurate and comprehensive result than a point of care, or also termed immunoassay, a presumptive test, helping those clinicians make safer prescribing decisions and tailor interventions. There is evidence that consistent toxicology monitoring through definitive testing improves engagement, supports recovery, and mitigates return to use. Most studies and CDC reports notes that careful monitoring is a key element of the comprehensive OUD treatment program. Definitive testing, like that done at Aegis, is best understood as a clinical support tool that's going to help reduce the risk of return overdose by these things: identifying undisclosed use or unintentional exposure, what we might even consider a poisoning to an illicit substance, confirming medication adherence with MAT, and forming timely interventions if return to use occurs. So we sought to evaluate return to use by looking at data with results reported from our laboratory between 6/1/2024 and 9/30/2025. The focus of this analysis was to look at use, potential reuse of fentanyl and fentanyl-containing substances. Individuals had an initial sample within that defined time frame and tested positive for fentanyl by definitive testing were included. Results were excluded if there were any samples within that time frame where there was an opiate or opioid utilized in the pain management realm that was indicated as prescribed, if less than 365 days had elapsed between the first and last sample collected per individual, or if that individual had provided a sample for testing to our lab prior to 6/1/2024. In total, there were 402 individuals that met the criteria that I listed in the previous slide. Of those meeting inclusion criteria, I wanted to note 367, so 91.2%, either had a medication commonly prescribed for the purposes of MAT. So we looked at buprenorphine, methadone, and naltrexone, indicated as prescribed at the time of the order placement, or tested and detected, and at least one of their samples included in this analysis. Details regarding some of the select high-risk substances that were requested to be tested and reported and were detected with fentanyl are going to be found in this table below. So looking at that far left column, you'll see the different classes or analytes that we tested. You'll see the number of the total request for those tests, and then the co-positivity we found with those substances with fentanyl. So the top two are in our novel psychoactive substance testing, and the highest rates, which were at 52%, that were co-positive with fentanyl, were xylazine and or medetomidine. For those that are not familiar, those are both adulterants in the illicitly manufactured fentanyl space and are both veterinarian tranquilizer substances. And then the second highest at 50% co-positivity rate were samples that included both fentanyl with a fentanyl analog and or anitazine. And then as we talked about that fourth wave, this is kind of confirming that data that, anywhere in upwards of 38 to 34% of our samples contained a stimulant such as methamphetamine or cocaine. We did also look at alcohol and heroin as well. Of those individuals with results that met the criteria, 116 individuals, or 28.9%, had zero samples that reported with a negative fentanyl result within the time frame of the analysis. For those individuals that did have at least one reported result without fentanyl detected, so that's 286, or 71.1%, we did additional analysis and identified timeframes for return to use. So we aim to assess return to use events by looking at the results that were collected and reported to those providers based on the individual's initial result. So we evaluated longitudinal results for each individual to identify their first sample that did not have fentanyl identified, and from there we defined a return to use criteria based on positive findings for fentanyl that were a positive finding for fentanyl or norfentanyl in an oral fluid specimen, which would indicate use of fentanyl within the previous 48 hours, as an oral fluid specimen is going to detect recent use. Included presence of parent fentanyl in a urine sample, or presence of norfentanyl that exceeded our upper limit of quantification for that analyte, which is 1,500 nanograms per milliliter. The second and third criteria that were included, I wanted to clarify here. They were included to rule out any fentanyl detection that could be secondary to protracted elimination after chronic use. This is a phenomenon that is described in literature. As we know, fentanyl is a lipophilic drug. 101 individuals, or 35.3%, were identified as having a return to use event based on the criteria. So days that elapsed between the receipt of the first sample and their return to use event were a mean of 238 days with a median of 256. The days elapsed between receipt of the first sample per individual with negative findings for fentanyl and a return to use event are 124 days and 87 days, respectively. Our data supports significant copositivity in our samples between illicitly manufactured fentanyl and other drug classes. So there's illicit adulterants, namely xylazine and medetomidine, designer fentanoids, opioids such as nitazines and fluorofentanyl and fentanyl analogs. And as we discussed, again, that fourth wave of the stimulant being combined and co-positive with the fentanyl, methamphetamine, and cocaine specifically. So on average, individuals with the assessed population experienced a return to use between 8 and 9 months after the initiation of treatment, which was identified as the date on which their first sample was received for AEGIS testing. The analysis of our data supports previous publications regarding a return to risk use. Individuals that use drugs more frequently are encountering substances that contain drugs of multiple classes or are concurrently seeking out substances of various types. This is supported by data discussing the current phase of the epidemic and this polysubstance use. Our data supports this notion, demonstrating significant copositivity of those illicitly manufactured fentanyl positives with the illicit adulterants, designer opioids, methamphetamine, and cocaine. As highly adulterated drugs become increasingly pervasive, healthcare providers can utilize testing to gain an improved sense of what individuals are seeking treatment for and what they've recently encountered. OUD is recognized as a chronic illness with a tendency for relapse, similar to any other long-term condition. And those individuals are going to experience variations in their ability to achieve and sustain treatment objectives over time. So it's necessary to both remain aware that return to use is going to likely occur and equip the providers with the means to effectively identify return to use when it does occur, such as as the type of testing that we do here at Aegis. I would first just like to thank Dr. Schrecker for assisting with data collection and interpretation for this presentation. I have included our entire clinical team and a dedicated phone number and email that you can reach us if you have questions related to this presentation or just general questions. We would be more than happy to help. And I would like to end by just saying thank you for attending.